What is the next priority action? That means all of this is right? And this is caring for a client on chemotherapy with the temperature of this 100.5, 101.5, and getting chemotherapy. What do you want to do? Notify the MD, or just start giving the patient antibiotic, or place peripheral IV access, or obtain full sets of lab. Think about it. Don't just jump and pick an answer. Put yourself, every time they give you a question, I want you to tell yourself, the NCLEX is asking me what I'm going to do. And see yourself, I'm already on the ward. I'm taking care of this patient. What would I do? On chemotherapy, I'm on the ward seeing the patient with the temperature of this. What do you want to do? What do you think you should do? Do you call the doctor and say, hey, doctor, your patient, this is what is happening? Or you just start giving the patient antibiotic? Does that now make sense? When you start doing that, that is the process of thinking. Just think about it. I always provoke you to think, because that is what you do. When you go to start working, there's no book anymore. It's like bringing yourself in that situation and seeing the individual like, what would I do? So put the patient there, standing there. This is the patient. You are the nurse, and the client sitting there on the table or on the bed, and you seeing the client. What would you do? I call the doctor right now. If I call the doctor right now, he's going to say, patient temperature is 101.5. Okay, what is about the blood pressure? You care about the temperature more than blood pressure? If the patient in septic shock, don't you think I need to know the blood pressure? I need to know the heart rate, bunch of that stuff. Blood pressure, heart rate, temperature, all together, it will tell you if the patient is in shock or just a simple temperature. Then you can decide. At the same time, if you look at the numbers, antibiotic, you can give antibiotic without a fortune. So that's gone. And when you place IV, you take some courses where I need to obtain full set of lab, because if I call the doctor, he's going to be mad. So I'm going to get full set of lab. Which one? Think about it. That means I got to do something quickly. All of them have a problem. I've always said, anybody who is in the emergency room is a priority. But when you have 1 second, well, and you have 4 patients, well, that second goes to only 1 person. So pick one, right? 4 patients. I have COPD. My prioritization, I divide it. I look at the situation and what is the effect of it? The modifier that they're telling me, COPD, complain of what? Heart palpitation. What happened? Beta agonist. Schizophrenia patient, complain of what? Auditory hallucination. Meniere's disease is complaining of what? Room spinning, right? And pericarditis is complaining about what? Chest pain when he leans forward. COPD patient, beta agonist. It's schizophrenia patient, auditory hallucination. Meniere said the room is spinning. Pericarditis said chest pain, but is relieved when he leans forward. Agonist speed things up. Okay, so they bind to beta agonist, they make things up. Palpitation is fine. It's like albuterol. So this can be an albuterol. Schizophrenic patient with auditory hallucination is not good. It's bad. You have to find the content of the auditory hallucination. Is it going to kill anybody? This is dangerous. I know everybody say psych is always not, this psych problem is dangerous. If a schizophrenic patient is hearing things, well, it's going to kill you. It's going to kill him. You always have to find the content of the auditory hallucination. What are you hearing? What are the voices telling you? Meniere patient, they're going to have room spinning. They're going to feel it. This is the same as dizziness. They feel dizzy, they feel nauseated, they want to vomit. It's not a problem. And this is consistent with pericarditis and is relieved when you lean forward. So don't pick this because you think it's safety. Okay. Schizophrenia patient, hallucination is bad. This is why formula does not work. Everybody think you psych patient, you always have to do physical finding first. No, this is not bipolar patient. This is dangerous. If you see a schizophrenic patient, every hallucination is fine, but when they can hear something, you got to worry about your safety. Which client situation requires intervention? Several clients, ADHD, palpitation, methylphenidate, CHF, leg edema, cirrhosis, severe pericarditis, schizophrenia, fainting spell after zaprasidone, and schizophrenia complain of fainting spell. I have something I call B sharp, and I know there's a bunch of things here. All it means is I have to be sharp, not unexpected finding. So I look and see, is this consistent with this problem? Am I surprised, right? Like, are you surprised completely about what they're telling you? If you're surprised about it, then it's wrong. That is the key. Are you surprised? That is what it means to be sharp, not unexpected finding, right? And that means I have to look for a breathing problem, electrolyte shock, and sepsis, airway, neurological, and pain. If I don't see it, then I said, okay, now I have an option. I look at each of them and I said, is this related to what I expect in this condition? If I don't expect it, then it's wrong answer. If I expect it, then it's the right answer, right? Right answer means is a wrong, you don't have to pick it, right? If I don't expect it, then that should be something, your answer choice you have to pick. If it's an expected finding, then ignore it. Well, if I give you a methylphenidate, it's a stimulant. A stimulant will make you go up. It's an upper symptoms, right? Is this not an upper symptoms? Your heart rate is going up, right? It's fine. You have CHF. Well, what do I expect? Your leg is not going to be like normal. So if you have cirrhosis, right, and you have severe pericarditis, you see this word I put it there, it will trap a bunch of people. So if it trap you, next time, don't look at it anymore. Don't worry about it. Cirrhosis patient, their bilirubin is very high. When your bilirubin is very high, your skin is going to itch. Is that more important? Is it going to kill you? Or you expect that to happen? Yeah. Test taking strategy. Number 4 is what you left with. So don't pick number 3 because I put the word severe there. Once again, don't do that. Those kind of words, severe, acute, chronic, ignore those words, okay? Those like, there's nothing like that. Pay attention to the situation. Not it's acute, it's chronic. No way. People get sick with chronic problems. CHF is not an acute problem. It's a chronic problem. ADHD is a chronic problem. Schizophrenia is not an acute problem. It's a chronic problem. It doesn't just go away. So don't worry about those kind of words, severe, throbbing, all those things. Ignore it. What is the situation telling you? What exactly is the situation telling you? Can you figure out what I'm trying to say in number 4? Fine. If you don't know test taking strategy, you have taken 1, 2, 3. You already eliminated it. Therefore, you should be able to pick number 4. Don't just run away from it. If you eliminate 1, 2, 3, you got to pick number 4. Then break it down. Like I said, content, right? What you know. Usually give them Ziprasidone. For what? They are psychosis. I mean, that's what they need. Second generation antipsychotic. Then I said, wait a minute. Why would the NCLEX give me Ziprasidone in the schizophrenia patient? I need to worry about one thing alone. That is the most important side effect of second generation antipsychotic. They causes weight gain. Ignore it. They causes diabetes. Ignore it. They causes hyperlipidemia. Ignore it. They are not that important. All of them, clozapine, olanzapine, they do that. They have cholinergic, anticholinergic, they have hypersalivation. All of them is not right. And ziprasidone does not cause priapism. Okay, it's not the same. Ziprasidone does not cause priapism, right? So that's QT prolongation fainting spell. That means, and the problem with the QT prolongation is syncope, sudden death. So that's why this guy is in trouble. Let's care for several clients. Which client situation require immediate intervention? Client with what? Gastroesophageal reflux, complaining of constipation after sucralfate. IBS, complaining of xerostomia after dicyclomine. Schizophrenia, complaining of what? Drooling after olanzapine. Stroke, complain of headache after what? Tenecteplex. You should get all this question right. Try to, like, as I've told you the previous one, if you use that strategy, content-based what? Prioritization, you are being sharp and not expected, then you'll be able to get it. Good. Constipation, sucralfate. You see what I've done? Connect them. Forget about the words. Connect them. Does it surprises you? Does it surprises you at all? IBS, xerostomia. I always say do a puzzle. I'm a visual guy. That's why I draw these things. IBS, xerostomia, dicyclomine. Does something ring in your ear? Clozapine, drooling, olanzapine and schizophrenia, sorry. And then stroke, headache, tenecteplex. Reflux, if I give you sucralfate, I call it cement. It's a cement. It coats the intestines completely. Your stool is going to be a cement. You're going to have constipation. I ignore it. IBS, they need dicyclomine to slow things down. Dicyclomine, anticholinergic agent. What is he going to do? Dry mouth. Dry mouth, xerostomia is not killing you. That's dry mouth. Ignore it. Schizophrenia, you give them olanzapine. This is a second generation antipsychotic. They have hyper salivation. They salivate. You're going to drill if your mouth is full of saliva. This is not an airway problem. Don't get trapped with it. That's why I said pay attention to the content in that question. Because somebody probably have told you drilling is always a priority. Well, I put it in my big shop, but I always say pay attention to the situation because Bell palsy patient also was drilling, right? What is happening to this patient? Salivation, constant with second generation antipsychotic. Yeah, ignore it. You have stroke. I give you this. You can't recognize this medication. Look at the name. Place, Arthaplex. It's a thrombolytic. If I give you a thrombolytic and you have headache, You bleeding in your brain. So I got to see you. And is prepared to administer prescribed medication to assigned client, which client situation requires immediate intervention. Now, I change the question. You have the medication. You are about to give it to the patient. 4 people. You tired. You went to lunch. You just tired. You want to take a break. And now you are 1 a.m. 1 p.m. medication is due. Each of them have their situation. Who do you have to provide medication first? That's the situation. Put yourself in. You are the one taking care of these 4 patients. They all need their medication. So what do you want to do? Act it carefully. Otherwise, you get it wrong. CHF, Digoxin. Patient is an adult. Hold it if it's less than 60. It's 62. I'm fine with you. Pericarditis. We give you Colchicine. What do I worry about pericarditis patient? The priority, number one, is cardiac tamponade. I don't see cardiac tamponade here. There is no cardiac tamponade. Just the blood pressure is normal. Furosemide, COPD, and CVP 29. And Benztropine for drooling, shuffling gait, and clozapine. Break it down. Clozapine is a second generation antipsychotic. What are the side effects? Of course, it causes NMS, EPS, it has QT prolongation, it's agranulocytosis, all of them, a bunch of them. Fine. Look at what they've given you. When you're drooling and you're shuffling your gait, what do you think? This is the buzzword for a diagnosis. When I give you a case, this is what I put in it. Drooling and shuffling gait is EPS. What kind of EPS? Parkinsonism. It looked like Parkinson patient. Parkinson patient would draw and they shuffle in their gait. Therefore, if I give you a clozapine and you're drilling and shuffling your gait, you have Parkinsonism. This is not dangerous. I give you Benztropine to take care of it. Remember, the drilling is coming from hypersalivation. That was the same question we saw. They just salivating and they shuffling their gait. It's extrapyramidal side effect. So it's not dangerous. It's not NMS. COPD and your CVP of 29. Think about it. COPD and the CVP 25, sorry. Do you see a connection? This is your lung. And this people's CVP goes up if they fluid overloaded. How can COPD causes fluid overload? How can COPD causes fluid overload? Unless this is your heart. Unless the lung is affecting the right side. And if it affects the right side of your heart, your central venous pressure is going to go up. This is what we call pulmonary. And that is right, severe COPD. You have to have severe COPD to affect the right side of your heart. This patient is drowning, is bad. He has cor pulmonale. He needs laces. Flush him out. So that's your right answer.